Recording start कर दी. That's good. Okay, Bismillahirrahmanirrahim. Thank you very much, all of you, for joining after a long break in between. The last time I probably presented was about 6 months ago, maybe more than that. Uh, and then afterwards, I thought that, well, Manut said that we should restart. So I was thinking what to talk about. And then I realized that this is probably one of the topic that we should start from: etiology, the reason, the cause, the things behind what causes the mental disorders. Or
Sorry, sir, I'm interrupting, but I think recording hasn't started yet. आप check कर लें please एक बार.
there is definitely recording there. So don't worry.
Okay, okay,
I
sir.
can see
Okay,
it
sorry.
for a
Sorry
minute.
for interrupting.
No problem. Okay, so etiology is related to the cause of the psychiatric morbidity. When I was thinking about the etiology, I thought that this is something related to it. मेरा इश्क हो, तेरी जात हो, फिर हुस्न इश्क की बात हो, कभी हम मिलें, मुलाकात हो, कभी तू हो चुप, कभी मैं हूं चुप, कभी हम दोनों की बात हो, कभी मैं तेरा, कभी तू मेरा, कभी सोबतें, कभी रंजिशें, कभी दूरियां, कभी कुर्बतें, कभी उल्फतें भी जीत हो, कभी यार हो, कभी याद हो, कभी तेरा दीदार हो, सिर्फ मेरा इश्क हो, तेरी जात हो, कोई ऐसी मुलाकात हो. And whenever we are talking about etiology, there is always a confusion. I was just having a word with Kamran and we were talking about the formulation. And when in exam situation you are presenting, this is the key area that you have to talk about. Well, even if the time is short and maybe we are not able to assess the all of the etiological situations in a patient's illness, but at least we should be able to highlight some of them. And what you should be talking about etiology in the exam, that is very important. So just few sentences that you have to make sure in 45 minutes that you should talk about, and then you should be able to move forward. So etiology in day-to-day practice is the key. When sometimes I'm seeing a patient and I realize that this is etiologically, genetically predisposed condition, and there is a definite relationship between the genetics and the cause of psychiatry or psychiatric morbidity, then of course the things are different. But when we know that the cause is in the situation, social, psychological, personality, environment, or anything related to it, then of course the management is relatively different. So to know the etiology is the key to unlock the door to psychiatric disorders treatment. This is what I perceive. And unless or until you know you have the key in your hand, the management and the prognosis is compromised. Most of our psychiatrists and again psychologists are talking about how to do this, how to do that, where to intervene, what to say, what to talk. But assessing the cause is important. And it's very complex. It's not very simple that we'll be able to talk to the person and we'll be able to understand, okay, fine, this is the relationship between the cause and the event, and this is what is causing this mental disorder. So that key is important for you, all of you as a psychiatrist. And unless or until you have the key, again, the future effect is very much compromised. So the complexity of causes in psychiatry are manifold. And again, when we are trying to talk to the patient, we are not just talking. We are actually assessing everything. And etiology is one of them. Now, when we say that, okay, fine, the death of a mother was the reason for this psychiatric morbidity, We have to make sure that there is a temporal association between the death of the mother and the onset of the illness. And if we are not able to make that link, then that could be just the precipitant or maybe a perpetuating factor and not the cause or etiology of the psychiatric morbidity. So the temporal association between the incident and onset of psychiatric morbidity is retrospectively very difficult to establish. It's difficult, but it's not impossible. You can do that only if you have appropriate knowledge about it. And then the cause and effect. So when we know that this is the reason for this psychiatric morbidity, then what are the consequences which are happening for this morbidity and how we should proceed about it? So we have lots of indirect mechanisms, and you know that, okay, objectivity should be there, collateral information should be there. We have to talk to the family members, we have to talk to the people who work with the person, we have to talk to the people who are actually directly providing the care and services to the patient. Here in the West, most of the time, patient is not living with the family. They are living at some other place where there are care providers, especially in UK and Canada, who are actually taking care of the patient's medication, patient's food, patient's day-to-day things. They are part-time or full-time people who are doing this stuff. So the government is providing those things in various level. But in Pakistan, most of the time, the family is providing the care because there is no such concept of providing care to the mentally ill otherwise. When predisposing factors are highlighted, especially again in the exam situation, the classification makes further things complicated. One of the key factors, predisposing factors that we should be talking in an exam is the genetic endowment and the environment in the utero as well. So how was mother's health during the pregnancy? In most of the time, in most of the cases in Pakistan, I am not able to, again, get any information related to it unless or until the patient is about in 20s or 30s, where the mother is available and she would be able to give us some of the clues to this. So genetic endowment and in utero, what was mother having? What is, again, various possibilities of problems in mother, how she was carrying the baby, was she taking any medication, what was the effect of the medication, was she appropriately evaluated, if there was a genetic component involved, was any amniocentesis or any genetic assessment was carried out. All of these phenomena are unfortunately compromised in psychiatry, especially as all other areas as well. We are treating the disorders, but we are not seeing what caused this disorder. And if we are not seeing it, then unfortunately we won't be able to correct it. So I was seeing one person and he was presenting with typical OCD, and we were trying to assess and trying to intervene. And after number of times I've seen him, I thought, well, maybe I should go for an MRI and see why this OCD is persisting. And we were able to see hypoxic brain injury and encephalomalacia, which in and around the temporal area, which was causing the obsessional symptoms. So whole of the treatment strategy changed. So this is important. So you have to understand this, that again, talking to the mother about in utero and the pregnancy and further consequences is important. A physical, psychological, and social factors in infancy. So when was the child able to? We always talk about it, and we sometimes write it in our notes as well, that there is nothing significant in the infancy or childhood. But we never ask about it. Was the child vaccinated properly? Was the child having traumatic incidences? Was the child having any educational problems? Was the child having some other issues related to it, psychological and physical? But we don't ask them. Early childhood, most of the time, the patients never talk about it, and we don't ask about it as well. And physical, psychological, social, and personality. So, from starting from the genetics, and then from the mother, and then the physical and psychological situations, then the schooling, then the childhood, everything makes a difference. And especially when the child is above the age of 16 or 18, assessing the personality and further progressing it. We may be able to say that this gentleman is having lots of personality issues, which are actually, again, maintaining factors. But the personality factors are also most important key predisposing factors. So when you are talking about the predisposing factors, these are the 5 components that are important that you have to say in the exam situation. That the predisposing factors in this person, there is no genetic abnormality reported. There are no in utero or afterwards any problems. However, the child was not able to go to the school till the age of 6 or 7. He was interacting fine in the school and was an average student, but the average student never means that he is, again, just scoring as an average. Average student means everything. How was he was interacting with the friends, how was he was involved in the games, how he was involved in other activities. So those things are important as well. And then after that, the personality, important for personality traits are also predisposing factors. Then we come to the precipitating factors. The precipitating factors, events that occur shortly before the onset of disorder and which appear to have induced it. And 3 domains, again, physical, psychological, or social, could be the causes. So all 3 should be, again, said in the examination. You have to actually talk about them, that the precipitating factors, as far as I was able to assess, the physical morbidity, there was nothing reported. Psychologically, he was shy, anxious, sensitive kind of a person, and there were again some problems in the family, whatever you would be able to find out. Maintaining factors, which we call as perpetuating factors as well, which makes the illness prolonged. For example, in early stages, many psychiatric disorders lead to secondary demoralization and withdrawal from the social activities. Stressors, this is again a very complex situation. Uh, I still remember that girl. I was treating her for schizophrenia. And when I started the treatment, she was 19. So she just got admission in first year or second year of the college. And after 3 years, when she recovered completely and there were no active psychotic symptoms, she started expressing about the depressive symptoms. And the key thing which she said to me, that sentence is still stuck in my mind, and I still quote it at number of places. She said, डॉक्टर साहब आपने मुझे ठीक कर दिया है, लेकिन मेरी जो जिंदगी के 4 साल जाया हुए हैं उसमें मेरी कुछ सहेलियों की शादी हो गई है, कुछ सहेलियां ग्रेजुएशन करके मास्टर्स कर रही हैं, कुछ ने जॉब शुरू कर दी है, कुछ बाहर चली गई हैं, और मैं उसी जगह पे खड़ी हूं जिस जगह पे मैं आज से 4 साल पहले खड़ी थी. And that was unfortunately a big blow to me. What should I say to her? How I should be able to convince her that these 4 years, unfortunately, the acute psychotic illness and further consequences to it, what I have done to compensate that, and what should I be doing about it? That was a big concern for me. And I still feel that so many times, unfortunately, we are able to see them, but sometimes we are apathetic and we are not reacting to the emotional concerns the patient has. Stress is one of the things. As I said to you about the demoralization of psychiatric morbidity, this is the concept again, a huge topic. When a psychiatric patient starts the treatment and when he recovers, what are actually the maintaining factors which are actually playing a key role in the outcome and the prognosis. So we have to understand the consequences of stress, physical, psychological, social, and provoking factors. As we all know about the concept of schizophrenic mother. Now, I won't be able to remove the mother who is having those tendencies. Psychologically, we have talked about it a number of times. But what should I do about it? How I would be able to convince the mother that she has to break up that umbilical cord and let the child grow into an adulthood and be a man or a woman. Independent thoughts, emotions, and reactions. That is the key as well. Now, psychological reactions, Jesper in 1963 wrote a book, and from its page 392, he suggested three criteria for deciding whether a psychological state is a reaction to a particular set of events or something else. So one, the events must be adequate in severity and closely related in time to onset of the psychological state. There must be a clear connection between the nature of the events and the content of the psychological disorders. For example, just giving the person should be preoccupied with ideas concerning their distant relatives. So people say that my uncle passed away, and after that, I started feeling that the life is just like this, anybody can go away. Although they say it, but I have to make a clear connection between those events and what he is saying. The psychological state should begin and to disappear when the events have ceased. So it's a clear again thing, like in exam situation, we all do feel stressed up. And when we are stressed up, there are reactions to it. Our outcome in the exam is compromised. But as soon as the exam is over, after 2-3 days, we are back to normalcy. If we are not, then that stressful state precipitated something and maintaining factors are there which are leading to the long-term consequences of the illness. So whenever you are saying in the exam situation, the predisposing factors, genetic is number one, family history is number two, death of the mother or the care providers is number three, unhappy childhood and not close to the father is number four, personality traits and previous episodes of depressive disorder during childhood and infancy are important. The precipitating factors, like I said, whatever the relationship makes it easier for us and is very much evident, although it's not easy thing to be done, but whatever it is. So a woman hears about the infidelity of the husband, and after that she started remaining depressed, although it was never proved that husband was actually having infidelity. But still, the woman was having these thoughts of depressive thoughts. She really, the precipitating cause was husband's infidelity and its information, or something else happening around? And then perpetuating factors like, again, financial problems, debts, ongoing marital problems, family issues, sibling rivalry, all those things needs to be mentioned here as well. Whenever we are doing etiological models, there are definitely, again, simplifying it and elaborating it. In exam, we use the reductionist model, but actually we should be using non-reductionist model. In exam, it's very easy to say that the predisposing factors was mothers having viral infection during the infancy. Precipitating factors were actually the job stress, and maintaining factors are family situation where the compliance to the treatment was compromised. This is a reductionist model. But non-reductionist model actually tries to explain everything in a broader way, which ideally we should be doing, all of us. So non-reductionist model is a better one, where we have to make a spreadsheet out of it. So if I say the mother's viral infection during the childbearing age was the predisposing factor, then I have to elaborate it and take further details about it. Why mother had a viral infection, from where mother had the viral infection, was the viral infection consistent for a longer period of time, what treatment options she was able to gather for it, was she able to get the treatment or not, was she immunized properly, was she able to again come out of it and have an appropriate immunity to further prolong the pregnancy, or was there some other things associated with it. So what I'm trying to say is that non-reductionist model explaining the causes and highlighting various important factors associated with it are actually would be able to help us in deciding about the prognosis of the illness. But reductionist model, of course, you just have to tone it down and say it and it's done. Neuroscience model, when we say that, again, it is very clear that all psychiatric morbidity carries genetic component or gene abnormalities. Medical models, so there is a serotonergic abnormality and it causes the depressive disorders. There are behavioral models that these kind of the behaviors are predominantly making this person suffer from this disorder. Developmental models, political models. Now, political models are anti-psychiatry models, not political models what we are expecting कि पाकिस्तान में हालात बहुत खराब हैं, सियासी माहौल बहुत खराब है, इसलिए psychiatric model. Political models are anti-psychiatry models. Most of the people who are anti-psychiatry, they talk about that, oh, ये तो सारों के साथ होता है. दुख तो इंसान की जिंदगी के साथ साथ चलता है. No doubt about it, this is a right thing to be said, but of course there are lots of, again, stigma and cornering the situation in this state. So that is key. And psychoanalysis model, we won't talk about it in detail. ये फैज अहमद फैज की एक नज़म है, अभी मैं सुबह इसका जिक्र कर रहा था किसी से, और इस नज़म के आखिरी सेंटेंस में जो बात है वो इट्स द की ऑफ द नज़म. ये फैज साहब ने जेल में लिखी थी और उन्होंने उस वक्त ये जेल में जब नज़म लिखी तो आई डोंट नो उनके दिमाग में क्या था, लेकिन दिस इज वेरी इंपॉर्टेंट फ्रॉम द साइकियाट्रिक पॉइंट ऑफ व्यू. इस वक्त तो यूं लगता है कि अब कुछ भी नहीं है, महताब न सूरज न अंधेरा न सवेरा, आंखों के दरीचों पे किसी हुस्न की चिलमन और दिल की पनाहों में किसी दर्द का डेरा. मुमकिन है कोई वहम था, मुमकिन है सुना हो, गलियों में किसी चाप का एक आखिरी फेरा, शाखों में ख्यालों के घने पेड़ की शायर, अब आके करेगा न कोई ख्वाब बसेरा, एक बैर न एक मेहर न एक रब्त न रिश्ता, तेरा कोई अपना न पराया कोई मेरा, माना कि ये सुनसान घड़ी सख्त घड़ी है, लेकिन मेरे दिल ये तो फकत एक ही घड़ी है, हिम्मत करो जीने को तो एक उम्र पड़ी है. If we see the good prognosis, then this second will pass away and the thought of having a depressive symptom will probably go away as well. However, we have to cope with it. हिम्मत करो जीने को तो एक उम्र पड़ी है. All of these things related to the etiology started long time ago. And historically in Greek literature, they talked about various fluids in the system which were causing various psychiatric morbidities. In Roman physicians, everything was related to the gods. There was a god of a grief. There was a god of, again, giving good health, and God for love, God for sorrow, etc., etc. So that was the cause, etiology of various psychiatric morbidity. In Middle Ages, everything went into darkness, and the cause and effect were actually all related to the poverty, hunger, and bad situation. But then in 19th century, things start reviving, and there were various terminologies which were used to assess the psychiatric etiology. Then the psychological models in early 1900s, starting from Freud and so many other psychologists, various explanations were given to psychiatric morbidity. And then now we are focusing more on genetic models, genome and other studies. All of these things carry equal weightage. And there is a weightage for everything because it carries some numbers. Now, this is very important. In scientific disciplines that contribute to psychology, psychological or psychiatric etiology includes clinical descriptive studies. So they were breakthroughs when people started gathering the data. Epidemiological studies, social sciences, experimental and clinical psychology, genetics, biochemical studies, pharmacology, endocrinology, physiology, neuropathology. Now, if you are in an exam situation and nothing comes up and you were not able to have enough time to talk about any etiology, you can talk about these things. You can talk about genetics. You can talk about the biochemical studies related to the predisposition of a psychiatric morbidity. You can talk about the endocrinological chronology and its association with psychiatric morbidity as a precipitant, and a neuropathology as a maintaining factors. So you have lots of things to say in the exam. Don't stay quiet. Say something, explain it, and make sure that whatever the patient, whosoever you are seeing, covers some of these areas so you have appropriate in an appropriate position to express yourself, the etiological causes. This is very important. Concepts and methods of epidemiology. Now, epidemiology and etiology are actually related. So when we say that genomic studies prove that schizophrenia has this chromosomal abnormality, this is actually on the basis of epidemiological study. And epidemiology means the rate and the ratio. This number of patients are present in this number of population, and these many peoples will be suffering from these many disorders. So you have diagnosed with schizophrenia. Now you know that in 1% of the general population, the schizophrenia exists. And the existence is because of number of the reasons. We have talked some of them in the previous slide as well. But we have to identify the population at risk, why this specific person developed the position of suffering from a schizophrenia. And if this is a case, then what is the case? And this case stands where in general population. So it is very important to understand these concepts of statistics and epidemiology if you really want to again talk appropriately in the exam situation. Aims of epidemiological inquiries. We always want to find the prevalence in a given population. Clinical and social correlates for psychiatric morbidity and factors that may be important in etiology. So the causes in the environment, we talk a lot that, okay, it was the bad mother, it was the financial crisis, it was the crunch of a family situation where sister got the divorce and came back. So he was having some psychiatric morbidity. But the concept and the applications should correlate with each other. And if we are not able to correlate them, in exam situation, we may be able to escape. But in real life situation, we may not be able to actually make sure that the prognosis is good in this patient. So the social class and subculture, like application, substance abuse, stigma and labeling, application is actually social exclusion from the community. Institutionalization, so negative behavioral effects of institutions. Social deviance, delinquent behavior. LGBT group, abnormal illnesses and behaviors, psychological consequences of the physical illnesses. There are so many other factors involved as well in etiology, and they all can be fit into the precipitating, predisposing, and maintaining factors, like transcultural studies. What is happening in the West and what is happening in the East? Why different cultures have different presentations. Like somatic symptoms are very common presentations in Pakistan and these kind of areas. But somatic presentations may not be as common as in the West. Why is that? So we have to understand that. Then memory distortions, limits are set to period over which events are to be recalled. Retrospective recall is always very difficult and very difficult to correlate with them. If you ask me, well, what happened in 1981, I won't be able to remember it. What happened actually in 1981? Although everything is there in my memory, in the chip inside my brain, but I won't be able to recall it. I have to explore it, associated with various events. Okay, in 1981, where was I? I was probably doing intermediate. I just passed FSC. Oh, yes, in 1981, we friends went to first time a trip to Murray, right? So then I'll be able to make sure that there is some correlation. But otherwise, exploring it into a specific domain is very difficult sometimes. And that is another reason why people don't want to put time and effort into this, so they don't talk about it. We always talk about vulnerability and protective factors. These comes in maintaining factors as well. So their good prognosis and bad prognosis are dependent on this. If there are protective factors, the wife is supporting, the children are actually helpful, and the old man suffering from dementia is receiving appropriate care and services, then of course it helps. Then the causes in the family. One of the most key factors, people who migrate, 70% of the population in Lahore is not actually from Lahore, they are from outside Lahore. Again, you go to any big city, Karachi, Islamabad, people living there are not actually born and raised there. They migrated from another place to this place. What are the effects of the migration? These can be precipitating factors, maintaining factors, or maybe predisposing factors as well. And all of these things lead to information processing, memory, evolutionary psychology, then genetic studies like family studies, twin studies, adoption studies, heritability, mode of inheritance, chromosomal abnormalities, linkage and association studies, copy number variant, exome gene sequencing, and genome-wide association studies. GWAS or GWAS is now a days a key in actually describing the etiology of psychiatric morbidity. I hope I'm making sense out of it. अगर किसी को समझ नहीं आ रही हो तो just please stop me and ask any question if they want to. Just to give you a little break from complex situation. रूठा है दोस्त ऐसे मुझसे कि जैसे मैं उसे मना लूंगा. इतना वक्त कौन जाया करे, इतने में मैं दूसरा दोस्त बना लूंगा. We are now talking about polymorphism in psychiatry as well. Like in Alzheimer's dementia, apolipoprotein E4, which is actually existing but expresses itself at some time back in long time in our ages, maybe in mid 60s or early 70s. 5-HT transporter gene, stress and depression. Now, these transporter gene is existent, but it is there as a predisposing factor, but the precipitant could be any stress in life leading to depressive disorder. Catechol-methyl transferase and dopaminergic function and dysfunction. So there are etiological other factors as well. If you are not able to recall anything in the exams, talk about something about them. Biochemical studies. Sir, in my opinion, this patient was precipitate. The illness was predisposed because of the problems with the serotonergic pathways as reported by the patient. He was 17 and having some relationship. And then post-mortem studies, receptor bondings, imaging studies. MRI and PET and SPECT scans gives a loads of information. If you have a patient who has an MRI, although the MRI was normal, you can use that as one of the factors predisposing, precipitating, or maintaining one. So why the MRI was done? Although the MRI is normal, what is the correlation of current psychiatric morbidity with an MRI? Why the MRI was done at a specific point and time? What happened that MRI was recommended, blah, blah, blah. So it can lead to some communication between you and the examiner, and at least you'll be able to move forward with it. Then pharmacology, he was receiving treatment for 3 years of time. All the SSRIs were tried and there was no response. So this means that probably the predisposing factors in personality and genetic abnormality are playing the part, and the maintaining factors are the existing personality as well. So you can cover up something and would be able to say something. Peptide factors, neuroendocrine factors, and gut-brain axis. Now, this is something very new and very much in fashion these days, especially when in Pakistan the nutraceuticals are promoted like peanuts, like chocolates, like candies. Uh, Half of the population of the Pakistan, it's not me who's saying that, as they are suffering from stomach problems, and most of them, they are actually taking the stomach medications. And now they say that the stomach medications and the stomach problems are related to the brain. Of course, we know that there is a relationship between the serotonin in the gut and the serotonin in the brain, and this brain gut axis leads to psychiatric morbidity and, of course, some somatic symptoms as well. And we can use this as one of the etiological factors explaining the illnesses as well. Again, if you won't be able to find anything, EEG, polysomnography, cerebral blood flow, activation paradigm, magnetoencephalography, neuropathology, all of these things could be part of the etiological process. Okay, so this is what I wanted to present. Now, any questions related to it? कुछ समझ आई या कुछ समझ नहीं आई?
नहीं सर, समझ तो आई है, थोड़ा सा वैसे कॉम्प्लेक्स सा टॉपिक है, बट ये सारा आपने चैप्टर ही बड़ा अच्छा कवर करा दिया, मेन एटियोलॉजी का, सो इट वाज गुड।
इसमें
अभी
कोई कॉम्प्लेक्स नहीं है, सारी चीज को एक्सप्लेन करने की वजह सिर्फ एक है कि in exam situation you should be able to say something related to the predisposing, precipitating, and maintaining factors. So I have given you so many things and so much information that all of these things can be talked about when we are talking about these etiological factors. अगर थोड़ा थोड़ा भी कहीं से याद रह जाए, then it will be able you will be able to say something about it. Got it?
yes sir.
Any question? Anything related to it? कोई क्वेश्चन नहीं है. So let's hope कि समझ
सर
आ.
मेरा क्वेश्चन है.
Please.
सर आपने ईटियोलॉजी तो मतलब कवर की है, लेकिन जो प्रैक्टिकली इश्यू फेस करना पड़ता है वो ये कि एट टाइम्स हम तो ईटियोलॉजी पे पहुंच रहे होते हैं, लेकिन जैसे हम कहते हैं लैक ऑफ इनसाइट ऑन द पार्ट ऑफ द पेशेंट, कि वो अपनी ईटियोलॉजी कोई और समझ रहा होता है, वो हेल्थ बिलीफ मॉडल का क्लैश हो सकता है, वो और नेचर ऑफ इलनेस. तो सर उस टाइम पे प्रैक्टिकली फिर एक्चुअल ईटियोलॉजी को एड्रेस करना बहुत मुश्किल हो जाता है, क्योंकि पेशेंट की नजर में उसकी ईटियोलॉजी डिफरेंट है, उसकी इनसाइट इनटू द इलनेस डिफरेंट है. तो प्रैक्टिकली हमें फिर ऐसी सिचुएशंस में क्या करना चाहिए?
अब इसमें दो चीजें, राइट? सबसे जरूरी चीज तो ये है, इंपॉर्टेंट की फैक्टर, आप जो बात कर रहे हैं वो रियल लाइफ सिचुएशन की बात कर रहे हैं, एग्जाम की बात नहीं कर रहे. रियल लाइफ सिचुएशन में when patient has not the insight and grossly having psychosis, and you are trying to explain it to them that this is actually the reason for your disease or entity, and he believes कि नहीं, मुझे तो जो फर्दिस आई थे उन्होंने जादू किया था, उसके बाद से मुझे साइकोसिस हुआ है, उसके बाद से मुझे ये सोच आनी शुरू हुई है कि मैं खौफजदा रहता हूं. Now, that is a part of the process of psychosis. It has got nothing to do with etiology. Usually the patients, when they are talking about these things, they are trying to express their psychosis. It has got nothing to do with etiology. And probably most of the time the patients are not interested in knowing the etiology as well. Most of the patients, they don't want to know the reason. They want the treatment. They want the best outcome. The etiology is mostly for you to understand, okay, if the outcome is good or bad, or better or worse, whatever you want to call it. So in real life situation, if there is a discrepancy between your thought process and the patient, you have to be at that state of time. If the patient lacks insight, you cannot convince him, and you should not try to do that as well. You have to just provide the information to the patient and to the care providers as well. You don't argue with them. You try to say that, in my opinion, these are the reasons for these illnesses. These are the maintaining factors, and these are actually what we can do to overcome these maintaining factors. Like माँ को एजुकेट करना है, बहन भाइयों को थोड़ा सा आपने समझाना है, पेशेंट को आपने बताना है कि ये करो ये करो ये करो. So those things are related to that. But you don't have to argue with the patient about the causation of the illnesses. If he believes that it was a kala jadoo which led to this problem, don't argue with him. Don't again negate him, because you'll be in trouble. He will refuse the treatment. He will have a again bad outcome for it. In exam situation, this is just to make sure that your examiners are satisfied that you know the topic, that you know all of these things that we have talked about, that something is again predisposing, precipitating, or maintaining factors. So you would be able to verbalize them. Jawab mila?
जी सर, thank you.
Okay. Any other question? No question. Okay. Anybody wants to cover any specific area for further things?
Yes, sir.
बताएं.
Sir, suicide. The models of suicide, the assessment of a suicidal patient, the management of a suicidal patient, and deliberate self-harm.
Done. So deliberate self-harm is a different topic than the
Yes, sir. I know. मैंने 2 topics बताए.
हो गया. ठीक है. हम suicide risk assessment and suicidal risk management जो है वो next time करेंगे. और इसमें तो कामरान बहुत help कर सकते हैं. वेस्ट में तो सारा वक्त इसी पे बात करते रहते हैं. Right? Okay. Thank you very much for seeing you so many people today. It was
Thank you, sir.
Start. Let's hope it is maintained and you people would be able to learn some topics. Okay. Allah Hafiz. See you next Friday, inshallah.
Allah Hafiz, sir.
Okay. Thank you.